This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Dr. Lori Conklin is an Associate Professor of Anesthesiology at the University of Virginia in Charlottesville. Dr. Conklin has no conflicts of interest related to this presentation. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
I'm going to be talking about preventing post-procedural respiratory depression. My objectives today are to define respiratory compromise and patient effects, outline the types of procedures most commonly requesting sedation, discuss common procedural sedation techniques, discuss post-procedural related complications and intervention strategies, outline current practice guidelines for non-invasive monitoring, describe the role of the respiratory therapist following the procedure, and then finally discuss current monitoring technology and equipment used by the respiratory therapist. Postoperative respiratory compromise represents a significant healthcare burden in terms of increased morbidity and mortality, along with increased length of hospital stay and cost of care. Despite this established and monetary burden, evidence suggests that current practice monitoring strategies are simply just not optimal for the rapid identification of postoperative respiratory compromise. The implementation of a rigorous and comprehensive patient monitoring system has the potential to improve patient outcomes and thereby reduce the costs of care. Given that patient ventilation and oxygenation are two separate physiological processes, a number of clinical care guidelines recommend monitoring of oxygenation by pulse oximetry, as well as the monitoring of the ventilatory function with capnography, particularly in high-risk patients. Respiratory compromise may be precipitated by an entire range of postoperative pulmonary complications, the most common of which is often referred to as respiratory insufficiency, arrest, and failure. These complications have a complex and multifactorial etiology, including preoperative, intraoperative, and postoperative risk factors. By definition, respiratory failure is defined as inadequate gas exchange by the respiratory system, such that our arterial oxygenation levels just cannot be maintained within normal levels. Respiratory failure is often related to respiratory obstruction and/or central drive failure. In both anesthesia and sleep, there is a loss of muscle tone because of a decrease in cortical influences and chemoreceptor drive. These factors lead to the loss of airway patency. In the case of anesthesia, reductions in airway muscle tone can be further compounded by the direct suppression of neural and muscular activity by the anesthetic agents themselves. Thus, loss of wakefulness is compounded by anesthesia-induced depression of airway muscle tone, along with depression of arousal ability, leading to a reduced response to asphyxia. Respiratory compromise tends to be more common in older patients with comorbidities such as liver disease, congestive heart failure, cancer, COPD, and cardiovascular disease. Additional risk factors for the development of respiratory compromise include obesity, emergent procedures, and patients already diagnosed with sleep-disordered breathing. The administration of opioid analgesics is often associated with respiratory depression. For that reason, the need for Narcan rescue therapy can provide insight into the development of respiratory compromise. Given this risk, the Anesthesia Patient Safety Foundation concluded that, and I quote, "continuous electronic monitoring of oxygenation and ventilation should be available and considered for all patients and would reduce the likelihood of unrecognized clinically significant opioid-induced depression of ventilation in the postoperative period." The pathogenesis of respiratory failure or arrest is influenced by so many patient-specific comorbidities or clinical interventions, often acting synergistically, that it's really difficult to define a single causative factor. The most common factors leading to respiratory failure are associated with one or more of three distinct processes: pulmonary shunt, respiratory muscle dysfunction, and opioids. Pulmonary shunt results from diseases that cause either airway edema or airway collapse, including pneumonia, pulmonary edema, trauma, inflammatory diseases, atelectasis, airway obstruction. Respiratory muscle dysfunction can follow two pathways. The pathway on the left suggests weakened upper airway muscles. That can occur because of impaired respiratory arousal, patient comorbidities, and residual postoperative neuromuscular blockade. This leads to airway obstruction, ultimately resulting in respiratory failure if an intervention does not occur. The pathway on the right involves weakened respiratory pump muscles, resulting again from impaired respiratory arousal, comorbidities, systemic inflammation, leading to muscle fatigue. This results in respiratory pump muscle fatigue, again ending in respiratory failure unless an intervention is made. Now, it is well known that opioid administration is associated with risk for respiratory depression, which can lead to respiratory failure or even death. The intensity and duration of the respiratory depressant effects of opioids are dependent on a number of factors, including the pharmacological characteristics and the dose of the drug administered, intrinsic patient biological factors such as age, gender, and even ethnicity, each of which can influence the metabolism and clearance of opioids. Patient comorbidities such as sleep apnea and obesity also increase the risk for respiratory depression. Finally, simultaneous administration of other sedating medications such as benzodiazepines may potentiate opioid-induced respiratory depression. Now, in this slide, we can appreciate that up to a certain point, patients can recover from opioid-induced respiratory depression. Along the red line, the oxygen saturation line, you can see that you start out at 100%, and with a period of apnea, it may decrease. And then as a breath occurs, it goes up again. And then with apnea, it goes down again, until you get to a point where the PaCO2 and the oxygen saturation levels cross. And at this circle right over here, that's referred to as lights out saturation. At this point, unless an intervention is made, and it can be something as simple as mask ventilation, patient death will ensue. Patients are at the greatest risk for respiratory failure in the first 24 hours following their operation. Specifically, 75% of deaths related to critical respiratory events occur during this time frame. Likewise, 81% of critical respiratory events occur in the first 24 hours post-op. Additionally, 77% of Narcan reversal of postoperative narcotics given for pain management also occur in the first 24 hours post-op. In short, the pathogenesis of post-procedural and post-operative respiratory compromise is a dynamic process. Closed claims analysis of patients experiencing post-procedural respiratory compromise discovered the majority were greater than 70 years of age, had ASA scores greater than 3, had hypoalbuminemia, meaning they were malnourished, had open versus laparoscopic abdominal procedures, and were more likely to have red blood cell and platelet transfusions during their operations, indicating a more complex operative course. Failure to prevent respiratory compromise may be because of the patient's postoperative location. For example, patients in ICU units experienced 35% of respiratory arrests. Patients located in general inpatient units experienced 26.8% of respiratory events. Patients in step-down units experienced 17.4% of respiratory arrests, while patients housed in the emergency departments only experienced 11.9% of respiratory arrests. More distressing was the observation that delayed interventions occurred in half. 50% of patients with respiratory distress with a median delay of 12 hours. And this delay in making an intervention is obviously associated with increased mortality. Multiple clinical trials have revealed the potential for respiratory rate to be an early indicator of a patient's declining clinical state. However, the respiratory rate is the least commonly documented vital sign. While the overall incidence of pulmonary complications is influenced by the definition and criteria used for evaluation, evidence to date suggests that general post-op pulmonary complications are relatively common, occurring in approximately 1.5 to 7% of patients. Additionally, respiratory compromise is well known to be associated with certain types of operations, such as burn procedures, major abdominal operations, and major vascular procedures. Evidence to date suggests that postoperative respiratory compromise is a major contributor to the risk of morbidity and increased mortality following surgery. A number of studies have shown that the development of postoperative respiratory compromise is associated with increased mortality. A 2012 database analysis of more than 20,000 patients revealed that patients who developed postoperative respiratory failure had a 300-fold increase in 30-day mortality. Fisher and colleagues demonstrated a 147-fold increase in mortality in patients who had undergone abdominal reconstruction procedures, who went on to experience postoperative respiratory failure, 14.7% versus 0.1%, and those numbers did reach statistical significance. In a 2005 study of more than 100,000 patients with respiratory compromise, as defined and demonstrated as a failure to wean from mechanical ventilation, had a 30-day mortality of 29% versus 2% in patients who had no postoperative compromise, a 1-year mortality of 56% versus 9%, and a 5-year mortality of 78% versus 42%. The authors also demonstrated an 87% reduction in median survival for patients who experienced general pulmonary complications compared to those who did not. Finally, to put all this data into perspective, when the authors extrapolated the findings to the national scale, pulmonary complications were estimated to be associated with 46,200 additional patient deaths per year. Not surprisingly, the development of postoperative respiratory compromise significantly increases the costs. Studies have indicated that, depending on the patient population analyzed, the projected annual cost of postoperative respiratory compromise ranges from $1 billion to $23.5 additional dollars each year, with a projected 2019 increase in cost of $37.3 billion. In a 2010 statistical brief, Weir and his colleagues list respiratory compromise as one of the most common conditions associated with rapidly increasing hospital costs. Postoperative respiratory compromise is also associated with increased length of stays, ranging from 4 to 14 days, again resulting in increased hospital costs from $12,000 up to $57,000 per patient. To put this in another perspective, postoperative respiratory complications have longer length of stays than cardiac complications, 22.7 days versus 10.4 days, again reaching statistical significance. Extrapolating these results, again, to the national scale, it has been estimated that respiratory complications result in more than 74,000 readmissions per year. Now, advances in medical and surgical technology have resulted in the ability to perform more complex procedures outside of the traditional operating room environment. Gastrointestinal endoscopy procedures, colonoscopies, endoscopic ultrasounds, and ERCPs are experiencing increases in patients undergoing procedural sedation. In addition, cardiovascular procedures such as cardioversions with or without simultaneous transesophageal echoes and cardiac ablations are also increasingly requesting procedural sedation. Vascular interventional radiology procedures, MRI evaluations, and radiotherapy for cancer treatments are also being performed more frequently under moderate to deep sedation. Finally, emergency departments across the United States are experiencing increased patient volumes, with procedural sedation cases becoming more frequent, secondary to scientific advances, more constraints placed on OR time, and other hospital-driven cost-containing measures. Additionally, patients undergoing procedural sedation in non-OR environments tend to have underlying and often significant comorbidities in addition to the procedural diagnosis that's getting them into the hospital in the first place. Closed claims analysis of patient characteristics following remote anesthetic procedures discovered these patients were again more likely to be elderly, greater than 70 years of age, had ASA scores between 3 and 5, and were emergent in nature. Now, in the emergency room environment, I understand that while the patients may be younger, substantial risk can still be present since the majority of procedural sedation cases involve emergent fracture dislocation reductions in patients whose NPO status may not coincide with the ASA recommended guidelines. Additionally, alcohol plays a role in the large majority of these procedures, and we all know the effects that alcohol has on gastroparesis. Conversely, patients who must wait a long time for their procedure to occur in the emergency department can end up being dehydrated, thereby perpetuating the transient hypotension that often occurs following propofol administration. Previous liver transplantation. In 2013, 5,913 orthotopic liver transplants were performed in the United States, with many of these patients requiring postoperative and preoperative procedural sedation, ERCPs. It is well documented that patients with cirrhosis requiring sedation are much more prone to sedation-related complications such as hypoxia and hypotension. And midazolam, or Versed, has been reported to even precipitate hepatic encephalopathy in cirrhotic patients. Also, more left ventricular assist devices, or LVADs, are being inserted as bridges to transplantation. But before the patient can be placed on the heart transplant list, he or she must undergo screening endoscopy and colonoscopy procedures. At the University of Virginia, these procedures are performed in the Digestive Health Center, which is one floor below the main operating room, under propofol sedation. And for those of you who have taken care of patients who have an LVAD, these patients possess a unique characteristic of non-pulsatile blood flow, making blood pressure monitoring quite challenging. Patients undergoing procedural sedation for cardiac interventions, including electrophysiology procedures and cardioversions, typically have more complicated comorbidities while being subjected to longer and more complex interventions in the cardiac cath lab. I know when I had my ablation last year, my procedure lasted 4.5 hours under propofol sedation, running I think at 160 mics per kilo per minute, so it wasn't a short procedure. Hemodynamic changes, cardiac dysrhythmias, and airway compromise must be monitored to ensure patient safety. Patients with peripheral vascular disease, and I'm a vascular anesthesiologist. Many of my patients have never been to a doctor. at least not recently, and many of them suffer from undiagnosed coronary artery disease. Most are current smokers, increasing the likelihood of underlying COPD. Current increases in body mass index, as well as prior obstructive sleep apnea diagnoses, also contribute to procedural sedation complications. These next few slides are going to demonstrate how the United States has evolved over the last 30 years regarding BMI trends. These figures are quite distressing from an airway control standpoint. Now, in the United States, obesity is defined as a body mass index of 30 or greater, with BMI being a measure of an adult's weight in relation to his or her height, specifically weight in kilograms divided by height in meters squared. In 1985, you can see that the majority of the United States was under 14%. The population was under 14% overweight. By 1990, the number is increasing. By 1995, you're seeing much more dark blue states, indicating up to 19% of those people living in those states are considered overweight. By the year 2000, we've got many states that are up to 24%. And by 2005, the lowest number is in Colorado, 15 to 19%, whereas many states have moved into the 25 to 29% range, with even 3 states being greater than 30. In 2010, that number is even more significant, as far as there are no more states whose population is in the 15 to 19% obesity range. Most states are 20 to 29%, with many more greater than 30. Aging is also an important consideration for risk of obstructive sleep apnea. OSA prevalence increases 2 to 3 times in older persons compared to individuals aged 30 to 64. In one community sample of people older than 65, 65% of them had undiagnosed obstructive sleep apnea. Additionally, this slide demonstrates what we all know to be true. As the prior slides shows, that the United States is not getting any smaller, our patients are getting bigger. This slide demonstrates the US is also an aging population. Now, by definition, obstructive sleep apnea is a sleep disorder that involves the cessation or at least a significant decrease in airflow in the presence of breathing effort, with apnea being defined using the American Academy of Sleep Medicine definition as the cessation of airflow for at least 10 seconds, but it may last for 30 seconds or longer. It is the most common type of sleep disordered breathing, and it is characterized by recurrent episodes of upper airway collapse during sleep. These apneic episodes are associated with recurrent oxygen desaturations and sleep arousal. Some signs and symptoms: nocturnally, you have snoring, witnessed apnea, gasping, choking, nocturia, and insomnia. Leading to daytime, non-restorative sleep, a morning headache, excessive daytime sleepiness, daytime fatigue, and even cognitive deficits. When taking a patient's history, patients with obstructive sleep apnea are more likely to have a history of cardiac dysrhythmias. They're more likely to either be currently treated for systemic hypertension or have been treated in the past for systemic hypertension. Snoring at night is also common. Now, OSA has an association with the metabolic syndrome. The metabolic syndrome is now currently recognized as an important contributor to the development of atherosclerosis and cardiovascular disease. OSA is associated with an increased risk of type 2 diabetes mellitus. OSA patients have double the presence of underlying coronary artery disease. And patients who have OSA and suffer from a stroke are more likely to die from this stroke than patients who do not have OSA. This correlation, interestingly, it still persists even when the researchers controlled for risk factors of age, gender, race, smoking, alcohol consumption, body mass index, diabetes mellitus, hyperlipidemia, atrial fibrillation, and hypertension. As we have seen in the previous slides, the United States is becoming a more obese population. Now, patients with the obesity hypoventilation syndrome are more prone to right-sided heart failure and increased pulmonary artery pressures, both of which can affect their response to procedural sedation medications. A large neck circumference, defined as 17 inches in men and 15 inches in women, may correlate with OSA better than body mass index. You should look at their mandible, retrognathia, micrognathia, or a significant overbite. These patients also have an increased incidence of obstructive sleep apnea, as well as a more anterior airway and a more potentially challenging airway should an intervention be required. The Mallampati score should be determined, as well as tonsillar size. Respiratory therapists have a huge potential role in the preoperative screening clinic in the diagnosis of patients with obstructive sleep apnea. The mnemonic STOP BANG is one scoring system that's very simple to use. We use it at the University of Virginia. It's on a grading scale: snoring, tired, observed apnea, blood pressure, BMI, this is greater than 35, age, older than 50, neck circumference, and male gender. Patients who score 1 to 2 have a low probability of OSA. Scores between 3 and 4 have an increased potential, whereas patients who score greater than 5 have a high likelihood of moderate to severe obstructive sleep apnea and should probably be referred for a sleep study. An aging population, increased obesity, but this is really important. It is estimated that as many as 70 to 95% of patients with obstructive sleep apnea in the United States are not yet diagnosed, and many who are diagnosed are not treated effectively. The anesthetic implications of obstructive sleep apnea include difficult ventilation, difficult intubation. Upper airway muscular tone, as I mentioned, is reduced with sedatives and opiates. The central response to carbon dioxide decreases with opiates. And the patient who has undergone a sleep study and subsequently been diagnosed with OSA and prescribed a CPAP machine must bring that machine on the day of the procedure. It needs to be checked out by clinical engineering, and then the anesthesiologist needs to communicate with the recovery room respiratory therapist so that after the procedure, the CPAP machine can be placed on the patient properly. It's also imperative that everybody on the care team be on the same page that the CPAP machine must be used the night following their procedure. That is non-negotiable. The ASA has defined sedation and analgesia as varying levels of consciousness ranging from minimal sedation all the way to deep general anesthesia. And it's really important for patient safety that all practitioners responsible for providing or assisting in procedural sedation understand each sedation analgesia level and recognize when a patient has progressed from one level to a deeper level and possibly require an intervention. Now this slide defines the ASA-defined levels of sedation and analgesia. It was developed by the ASA and approved by the House of Delegates on October 13, 1999. We can see there are 4 columns: minimal sedation, moderate sedation, deep sedation, and general anesthesia. And minimal sedation is not an issue. When you go from moderate to deep, and as anesthesiologists, we use a titration effect of drugs. In moderate sedation, no airway intervention is required. However, in deep sedation, an intervention, and it may be something as simple as a jaw thrust or a chin lift, may be required, but it still needs to be done. Spontaneous ventilation is adequate during moderate sedation. However, during deep sedation, one may begin to notice a downward trend in the pulse oximeter, meaning that spontaneous ventilation is no longer considered adequate. Now, in each of these 3, at least the cardiovascular function is maintained. Non-operating room procedural sedation should still adhere to the ASA standard equipment and monitoring guidelines. It is recommended that all of the people involved in administering sedation ensure the following items are readily available. Obviously, a reliable oxygen source, functioning suction. Many of us have been called to the CT scanner to intubate a patient, and there's no suction to be found anywhere, and if it is on the wall, it's not hooked up to anything. An ambu bag or other bag mask ventilation device capable of delivering at least 90% oxygen via positive pressure ventilation. Appropriate drugs for both sedation and unforeseen emergencies. Adequate ASA monitoring equipment that adheres to the current guidelines. An adequate light source. Sufficient space. Many procedure rooms are quite small in nature. Proper electrical outlets. A telephone or other reliable two-way communication device just in case you need to call for help. And the immediate availability of an emergency code cart with resuscitation medications and a defibrillator attached. You also need adequate support staff for the anesthesia care provider. Now, I work in a training and teaching institution, and every July and January we get new interns. If I am in an airway emergency or a sedation case that has progressed from moderate to deep sedation, it's much better if I have a trained respiratory therapist to offer assistance, because my intern, they will eventually get to a level of knowledge where they can offer help. They want to help, they just don't know what to do. So it's been my experience that a well-trained respiratory therapist can serve as a valuable member of the team in case you're needed for an airway emergency. There also needs to be an appropriate post-sedation recovery area. Current procedural sedation medication selection, it's really evolved over the last several years, and it's important for every member of the anesthesia care team to have at least a cursory familiarity with the drugs we use. Whereas in prior years, a benzodiazepine such as midazolam, also known as Versed, and fentanyl, the midaz-fentanyl combination, was commonly used. Today, current medication trends have been molded by patient desires for a more pleasant and a more complete sedation experience. Increased procedure complexity, as I went over earlier, requiring enhanced sedation and longer drug delivery. These changes have resulted in an increased number of requests by consultants for an anesthesiologist to maintain the procedural sedation. For example, in colonoscopies in 2000, 11% of the GI doctors requested propofol sedation by an anesthesiologist. Currently at the University of Virginia, the majority of patients receiving colonoscopies are under the sedation care of an anesthesia care team. Once we become involved, we employ a more balanced technique. Usually we combine an IV anesthetic with an analgesic agent, plus or minus an anxiolytic such as a benzodiazepine. And interestingly, emergency departments have also began implementing a similar technique. Now, when you look at procedural sedation drug selection that an anesthesiologist would choose from, we've got our IV anesthetics, propofol, dexmedetomidine, also commonly known as Precedex, ketamine, analgesics such as fentanyl, remifentanil, and anxiolytics such as midazolam. Each of these drugs have proper pluses and minuses. For example, propofol, we all know, is associated with dose-dependent respiratory depression. However, it does have antiemetic properties, so if you have a patient who suffers from postoperative nausea and vomiting, propofol is an excellent choice. However, it is associated with pain on injection, so you need to make sure that you use lidocaine to pre-treat to make sure that the propofol doesn't cause harm or pain when it is infused. Propofol is also associated with potentially severe hypotension, and it's good to know that. You must look at the starting blood pressure. You may have to give a medication to raise the blood pressure so that when you use the propofol and lower the blood pressure, you at least meet in the middle. Dexmedetomidine, commonly known as Precedex, has minimal ventilatory depression. It's also an anxiolytic, it's a sedative, and has analgesic properties. However, because of its mechanism of action, similar to clonidine, it's associated with pretty profound bradycardia. So if you have a patient coming to you who's already beta blocked with a heart rate of somewhere, in the low 50s, you wouldn't want to use dexmedetomidine as your drug selection of choice. It also takes a longer time to set up. Propofol is much quicker. Dexmedetomidine takes a few more minutes before you establish a good level of sedation. Ketamine is an outstanding drug. It's actually veterinary medicine, but when used properly in the human population, and I mean by 20 to 40 milligram of bolus, it's also associated with minimal ventilatory depression, and it does have remarkable analgesic properties, so it can be used for a balanced technique since it doesn't depress respiratory drive. It can be associated with increased secretions in larger doses, so if you're at all worried about laryngospasm, ketamine should not be used. As far as analgesics, we really just use in the procedure room fentanyl. Remifentanil, it doesn't have a lot of good qualities that would allow us to really use that drug very much, plus it's incredibly expensive. Whereas fentanyl, even though it is also associated with dose-dependent respiratory depression, it has a rapid onset of action and a very short duration. The key is titration. You don't just push 200 mics at once. You start with 25, and if they need a little more, you go to 50. Remember, you can always give more. It's really challenging to take it away. As far as anti-nervous medications or anxiolytics, midazolam, also known as Versed, is the most commonly used. It has rapid onset, amnestic properties. Nobody wants to remember their colonoscopy. Anxiolysis, so it helps people who come in who are already nervous. But it is associated with dose-dependent respiratory depression, particularly when combined with opioids. So you can get to the point where the patient is doing very well. They might move a little bit, and you give them midazolam, and it takes them from one level of sedation to a much deeper level, requiring an intervention. Opioid pharmacology and dosing I've included in this slide, and I've compared everything to morphine. Now, we don't use morphine much anymore, but many people understand and can identify with 10 milligrams of IV morphine. And so in this last column here, the dose of the other medications are compared with an analgesic level that would be comparable to 10 milligrams of morphine. For example, 100 mics of fentanyl is comparable to 10 milligrams of morphine. Hydromorphone, also known as Dilaudid, 1.5 milligrams of Dilaudid is comparable to 10 milligrams of morphine. And in the sedation and procedure room, we rarely use sufentanil if the tail is just way too long. And remifentanil, as I mentioned, it's just too short acting. You don't really get any benefits at all. The fact that consulting physicians are requesting anesthesia services for more complex off-site sedation procedures underscores the importance of maintaining patient safety. Once an anesthetic moves from a familiar, well-staffed, consistent operating room environment to a remote location, opportunities for sedation-related complications increase. The anesthesia team may be working with unfamiliar support staff that are not aware of how complicated procedural sedation can actually be, as medications are titrated to provide a narrow balance between patient comfort levels and over-sedation, resulting in a potentially fatal outcome. Additionally, the equipment used in remote locations may not be the same as what is present in the main OR. The anesthesia cart may not be adequately stocked, a discovery that can lead to a disastrous outcome because you don't know what you don't have until you need it. Finally, should a situation arise where help is needed and requested, valuable time can be lost waiting for the arrival of additional anesthesiologists or other care providers. The two most common complications that occur are hypoxia and hypotension. Now, since the majority of the medications that we use to provide adequate sedation and analgesia are also associated with respiratory depression, the finding that hypercapnia also occurs should not come as a surprise. Additionally, respiratory depression and insidious airway obstruction, particularly in larger patients with obstructive sleep apnea, can precipitate into marked hypercapnia, leading into a loss of consciousness and eventual cardiac arrest. Therefore, adequate monitoring must be diligently implemented and accurately documented in order to both deliver a safe anesthetic and to also protect the care provider should the record ever need to be reviewed. In 2002, the ASA updated its practice guidelines for sedation and analgesia, and one of the first recommendations was the performance of an adequate pre-procedure airway assessment and physical examination. Since you always have to have it in the back of your mind, positive pressure ventilation might always be required. This slide lists a thorough pre-procedure airway assessment and physical examination, and respiratory therapists could easily provide this service in the pre-op screening clinic. Another non-invasive monitoring technique involves the constant assessment of the patient's level of consciousness and sedation. This can easily be achieved by simply talking to the patient. If appropriate responses to questions are elicited, you can get several vital pieces of information. Number one, the patient's spontaneously ventilating. Number two, they're adequately oxygenating. And number three, their brain is getting circulation, so their blood pressure must be fine. Should the patient fail to respond to verbal stimulation, a light touch or shake can also be used to demonstrate arousability. Patients undergoing procedural sedation should be monitored continuously for adequate oxygenation. The importance of this vital sign is underscored by the fact that one of the most common complications, as I just previously had mentioned, associated with procedural sedation is hypoxia. Oxygenation levels can be determined using a pulse oximeter with audible and appropriate alarm levels. However, the patient's color can also be assessed for cyanosis. Sometimes the pulse oximeter simply doesn't work. It could be a refurbished one. All your other vital signs might be proper and your saturation is reading 75%, the patient speaking with you, answering questions properly. Are you going to intubate the patient based on one value, or are you going to say maybe my pulse ox isn't that reliable if the patient still has good color? Furthermore, pulse oximeters are also affected by hypothermia, vascular disease, the patient may have Raynaud's, or dark nail polish. The patient's ventilatory function also needs to be continuously monitored during procedures utilizing moderate and deep sedation, both via observation or auscultation. Now, while hypoxia is associated with increased morbidity and mortality, hypercarbia can be just as devastating. Elevated CO2 levels are associated with acidosis, cardiac dysrhythmias, catecholamine release leading to hypertension, and eventual loss of consciousness. So that patient that was answering questions properly is now the best patient in the world, not because you have them at a nice level of sleep, but because their CO2 is probably around 125 and they're obtunded. All patients receiving sedation shall undergo non-invasive monitoring to ensure adequate and sufficient circulatory function. Current standards for basic anesthesia monitoring clearly state that every patient receiving sedation shall have his or her circulatory function monitored continuously via an EKG. Additionally, every 5 minutes, the blood pressure and heart rate need to be evaluated. So what is the role of the respiratory therapist? Well, modern medicine has really evolved. It's undergone a dramatic shift into this complex, multifaceted system, an active process involving numerous individuals and mid-level care providers simultaneously functioning to achieve a common goal: safe, high-quality patient care. However, creating an environment in which all patient care providers function as a single unit or team has not been easy. It's been rather challenging. Past medical models were based on an entrenched hierarchy where the attending physician served as a form of a dictator, often demanding other healthcare providers acquiesce to their treatment plan with little regard or respect for outside input or opinion. Medical schools are now moving to educate new young doctors how to be better leaders, thereby promoting a more cohesive team. The respiratory therapist can expect to function as an integral part of the anesthesia care team, particularly during procedural sedation. Now, respiratory therapists, through classwork and routine job assignments and requirements and responsibilities, you all are prepared to manage risks specific to the cardiopulmonary system occurring in patients undergoing sedation. Respiratory therapists are uniquely qualified to assist in airway management in patients experiencing hypoxia, hypercarbia, and/or unanticipated increases in sedation levels, thereby allowing the physician to concentrate on patient physiology and prepare for other potential adverse events and any necessary interventions. A unique aspect surrounding the training of respiratory therapists involves the intense exposure and experience you all receive during your education in the usefulness of non-invasive capnography as the other vital sign. As we all know, at the most basic level, capnography refers to the study and measurement of exhaled carbon dioxide. What anesthesiologists may fail to appreciate is the deep knowledge respiratory therapists possess regarding the clinical application of capnography, particularly during moderate and deep sedation. Adverse events are often preceded by observable deterioration of patient conditions, leading to the conclusion that many in-hospital adverse events may actually be preventable with comprehensive, continuous patient monitoring. Unfortunately, despite the importance of patient monitoring, current patient monitoring strategies just simply may not be ideal for the rapid identification of post-op respiratory compromise. In 2009, an analysis demonstrated that almost 77% of patient records were missing at least one vital sign, and that respiratory rate was the least commonly documented vital sign. The early recognition of patient deterioration has been identified as the primary determinant of a successful intervention. Also, adverse outcomes tend to be more common at night, when patient monitoring may be less frequent or less comprehensive. Together, these data suggest that improved patient monitoring strategies may enable earlier interventions and improved patient outcomes. Given that patients are at the greatest risk for respiratory compromise in the first 24 hours postoperatively, these postoperative and patient monitoring strategies should be employed as soon as possible following their operation. Extreme and accurate respiratory rate calculation is a strong predictor of in-hospital mortality. In a 2004 analysis of 6,300 patients admitted to 5 different hospitals, it was demonstrated that a decrease in respiratory rate of less than 6 breaths per minute was the strongest evaluator of and predictor of mortality, with a 13-fold increase in the risk of mortality. In this same patient cohort, increased respiratory rate of greater than 30 breaths per minute was the second strongest predictor of mortality, with an associated odds ratio of 6.1. Unfortunately, as I previously have mentioned, respiratory rate is often the least well-documented vital sign, potentially because of lack of clinical staff time, lack of knowledge, and equipment constraints. A 2006 study by Orrick and colleagues demonstrated that the implementation of continuous pulse oximetry monitoring had beneficial effects on the timing and reasons for ICU transfers, such that there was a significant decrease in ICU stay duration, and thus a decrease in the cost of ICU care. In this patient cohort, the estimated cost of ICU stay was approximately $23,000 less when compared to patients who did not end up in the unit. In a similar study, and albeit this study is very small, it was demonstrated that 100% of bariatric surgical patients that were studied experienced post-operative hypoxemia, and they defined that as an O2 saturation of less than 90% for at least 30 seconds. They concluded that continuous pulse oximeter monitoring with an alarm set for less than 90% for at least 10 seconds would have captured all of these desaturation events. Tanzir and colleagues also demonstrated that the implementation of a patient surveillance system based on pulse oximetry with a nursing notification of alarm violation via wireless pager resulted in a reduction of ICU transfers from 5.6 to 2.9 per 1,000 patient days. Technological advances in the accuracy and size of non-invasive CO2 monitoring has really expanded its usefulness to almost all aspects of healthcare. Capnography is unique in that it can function both as a continuous measurement of patient ventilatory function via a numerical response, and also as a diagnostic device secondary to changes in the shape of the waveform, similar to an EKG. Additionally, capnography can also give the healthcare provider an indication of adequate cardiac output. For example, if CO2 levels are decreasing, gas exchange is not sufficient, warning those taking care of the patient of a potential cardiac arrest, and thereby alerting the anesthesia team member of the necessity for a pending emergent intervention. Since capnography provides real-time carbon dioxide and ventilation analysis, changes in CO2 can be detected instantly, whereas changes in oxygenation can go undetected for a longer period of time. One study found that hypoxic changes were discovered 12 to 271 seconds after capnography changes were documented. Since respiratory therapists routinely use capnography, you all have a great deal of experience accurately interpreting the capnograms during sedation cases. Finally, lethal hypercarbia can occur in patients with normal oxygen saturation levels. So in conclusion, post-operative respiratory compromise is a relatively common post-surgical event associated with increased morbidity and increased cost of care. The implementation of comprehensive patient monitoring strategies encompassing the continuous assessment of the proper respiratory rate, pulse oximetry, and capnography may enable early identification of post-procedural respiratory compromise. Advances in medical and surgical technology have resulted in the ability to perform more complex procedures outside of the traditional operating room environment. Many of these cases will be performed under moderate to deep sedation, necessitating the use of non-invasive monitoring. Finally, the training received by respiratory therapists allows you all to serve as leaders in many aspects regarding procedural sedation and non-invasive monitoring, both during the procedure and in the recovery room. Thank you.